Welcome everyone to this first webinar to support our methods, processes and topic selection consultation for health technology evaluation at NICE. We're here today gathered with three panelists to discuss some of the proposals we're making to support your understanding of the consultation. This webinar will be recorded and we will be having a Q&A at the end of the presentation. NICE plays a critical role in the healthcare system in the United Kingdom. Next slide, please. Our work is vital in ensuring rapid access to clinically and cost-effective health technologies to benefit patients, the NHS, and the life sciences. Evolving and improving our methods and processes ensures that we adapt to emerging changes in healthcare and in health technologies. Broadly, there's 5 reasons for the change that we're making today in how we assess and appraise health technologies. But of course, our overarching goal is to improve the health of people using the NHS and social care systems, and in doing so to support equitable access for people using the NHS. My name is Meindert Boysen. I'm the Director for Health Technology Evaluation at NICE, and I'll be chairing this session. Those 5 overarching reasons are, as health technologies rapidly advance, so too do the methods and processes of evaluation. The second is that reviewing our methods and processes allows us to remain agile and responsive to support rapid access to clinically and cost-effective technologies. Thirdly, our methods and processes underpin a robust and consistent and transparent decision-making by our committees that need to evolve as societal preferences change. Fourth, a greater need for alignment between the work of regulators, assessors, and payers in the United Kingdom to create an ever more receptive environment for emerging health technologies. And fifthly, COVID has put a spotlight on the importance of medical technologies such as diagnostics, devices, and digital tech. And these methods and processes allow us to level up with how we deal with these exciting technologies. You will find that through all our proposals, there's really clear benefits for patients, such as prompt access to innovative health technologies and an easier way to contribute to our evaluations. For the life sciences, they will find a responsive, flexible, and predictable way of working with NICE. And they, of course, will also see flexibility when the evidence we find is difficult to interpret and to analyze. And of course, we also provide a much broader, through these proposals, a much broader support for a comprehensive evidence base, including real-world evidence. And finally, for the NHS, it will ensure, our proposals will ensure a fair, equitable, and evidence-based access to innovations. And of course, in the end, as is important for our role, technologies that are clinically effective and value for money will be supported through our proposals. I'm confident that these methods, process, and topic selection changes will support the ambition laid out by the Prime Minister in his life sciences vision to make the UK the best place to discover, develop, test, trial, and launch, and in the end, adopt new technologies. This webinar is focusing on methods. There will be 3 other webinars where we will be talking about the highly specialized selection criteria, our processes, and the modifiers used in methods. So if you're interested in any of those 3, we'll give you later some more details about how you can participate in those webinars. Methods are about the sort of evidence that we require and how we take them into account when making decisions about the value of new technologies. Richard Diaz, a senior technical advisor, and Ian Watson, Another senior technical advisor at NICE will be talking you through the proposals we're making in our methods update. And after their presentation, I will be coming back with our third guest, Mark Russell, and we'll be having a Q&A with all panelists. Over to Richard first.
Thank you, Meindert. As many of you know, this has been a very large undertaking, and for good reason, as the methods underpin everything that we do in evaluating new technologies. Next slide, please. As a result, we divided the work into two main steps. First, what? So what is needed to change? And then second, how? How should we make those changes? So at the end of the first stage of the consultation, we consulted on the types of changes and whether there was a good case for making those changes. So that consultation ran from November to December 2020. And the responses that we got from that consultation fed into this stage, which is the how. And the responses were used to formulate answers to that question. So how should we make the changes that were proposed in the first stage? So throughout the whole process, we've engaged with a wide variety of stakeholders, including patients, patient groups, industry. We included pharmaceutical companies, companies specializing in medical technologies, and those that focus on diagnostics. We also included members from across all of academia, as well as the system partners in the government, the Department of Health, and the NHS. And we anticipate that this participation will continue throughout this consultation and during the implementation period. Next slide. Thank you. So these are the 5 areas from the first consultation into which each of the main cases for change fall into. So there's valuing the benefits of technologies, understanding and improving the evidence, the structured decision-making framework that's to be used by committees, and then how to deal with the challenges of particular types of technologies. And last but hardly least is the merging of a manual across the technology appraisals program, the medtech program, the highly specialized program, and diagnostics. So 4 programs merged into one. Next slide. So during the first consultation, we received a large number of responses. As you can see, we received 197 responses from organizations and individuals. From the breakdown, you can see that, unsurprisingly, the largest number of comments that we received were from industry, so from pharma, device industries, diagnostics, consultancy, industry bodies, that sort of thing. But we also had a substantial number of responses, over half from patient organizations, NHS, NICE, academia, individuals, and other organizations, which, when included with the patient organization, as I said, represented more than half of responses. So there was strong or general support for the majority of the proposals, which is not really surprising, as they were developed in conjunction with external participation. So, you could understand why many of the proposals are supported. And that said, there were some proposals for which there were mixed views, but that was mainly because those topics still had the how to be developed. And so without the how being defined, people were uncertain whether they could give the full support to a change without knowing what that change would be. So that's where this consultation comes into play, because now the how has been established and people can provide their comments on those cases for change. As I mentioned before, the consultation comments were essential in helping us to formulate the how. And so your responses for this consultation will be as important in helping us implement the changes. So, and now Ian will provide us some highlights of the new proposals that have been presented in the consultation. Next slide.
Yes, thank you, Rich. So yes, this slide just introduces the breadth of the proposals that we're presenting for this consultation. And looking across the 5 sort of areas or headings that we presented in the first consultation, you can see that we've introduced a number of proposals spanning the full breadth of those. So for the most part, in a large number of cases, they are developing from and seeking to implement those proposals in the case for change that met with positive responses in the consultation. We are able to move from those cases for change into fully developed methods that we present here. As I said, this spans across the 5 headings, looking at valuing the benefits of health technologies. There are proposals across modifiers and uncertainty and discounting, which I will talk about a little bit more in a moment. For the evidence base and how we understand and improve the evidence base, again, we have moved to implement a number of changes and improvements in how we handle evidence, how we look at things like costs and health-related quality of life, and present guidance on different types of evidence. We also present information and proposals on a structured decision-making framework and approaches in specific circumstances, and build on those cases for change for challenging technologies to implement really valuable proposals and refinements and some additional clarifications for those technologies. And what I'd like to do now, if I could move on to the next slide, is pull out a couple of those highlights to talk in a little bit more detail. One of the topics that I think will be of interest to a number of people on this webinar is the severity of disease. And we presented a case to introduce the severity of disease as a key consideration or a modifier into our methods. We propose an approach here that's built on additional weighting for those treatments and health benefits in the most severe diseases based on a technique known as quality shortfall. And we're going to present many more details on this at our next methods webinar, which you'll hear about later. So perhaps won't talk further about that topic here, but that rather move on to the topic of health inequalities. And this remains a really critical priority. I think it's really important for NICE and for many of our stakeholders that we consider health inequalities. We identified that there is a case to include consideration of health inequalities, but there are important challenges that need to be resolved first before we can do that in a formalized way. There remains the flexibility within our methods and within our principles and within our statutory and framework to consider things like health inequalities where they are relevant within individual evaluations, but we're not yet at the stage where we can introduce a specified formalized modifier just yet. So there's a little bit more work to do, and we've identified what tasks need to be done before we can go about doing that. A further topic of interest is that of discounting. This is a technique that is used to reflect how different costs and health effects are seen at different stages when they occur in the future at different times. And we believe there remains an evidence-based case for changing our approach to discounting, changing the rate at which we discount health effects, but there are wider implications and interdependencies of that proposal that are beyond the reach of this review, and that was identified in that case for change, and it remains the case now. So our proposal then is to retain the current methods while further conversations around those wider implications are pursued. So we retain our current methods in the meantime. Moving on to the next slide then, a further topic of very wide interest is that of uncertainty. As many of you will be aware, it's very important that we think about uncertainty in the evidence when we're evaluating health technologies, knowing that where the evidence is uncertain, that can create a risk for somebody having a technology or for somebody else elsewhere in the NHS whose healthcare might be displaced by additional costs for a health technology. So it's critical that we think about uncertainty, but it's critical that we think about it in the right way and proportionately. There are 2 aspects to this. The first is how we go about understanding and presenting that uncertainty within our evaluations and to our committees. And we present proposals here to fully and robustly characterize the uncertainty and clearly identify what that uncertainty looks like, or the nature of it, and how it affects and how it impacts on the health technology under consideration. We also identify some further work that we want to do to implement different ways to present that information or visualize the information around uncertainty, knowing that that doesn't necessarily need to be done through the methods guidance, the methods manual that we present, but could be done through other techniques, for example, in our template. So we identify some further work that we'd like to do there. And at this stage, we now present a slightly reduced emphasis on a technique known as value of information analysis. This is something that we identified a case to change, to expand our use of in the first stage. But we heard through the consultation some of the concerns that stakeholders raised about how we would go about doing that and how that would impact. And we, as a result of that, consider that it's appropriate to reduce our emphasis on that technique at this stage. Then, having understood and presented the uncertainty, we need to think about how that is considered within a decision, within an evaluation. And we present a proposal to use flexibility when evidence generation is particularly difficult. So this reflects the fact that there are some circumstances, such as those examples shown on this slide, where generating the full picture of the evidence is particularly challenging, and we want to avoid those circumstances being disadvantaged by excessive sort of going too far in considering uncertainty, and so allowing a degree of flexibility that really reflects what our committees were already doing and were already able to do, but we're now clarified that and then codified that and described it in further detail about what that flexibility looks like. So those examples are in particular diseases affecting children and rarer diseases, and also for innovative and complex technologies where it can be particularly difficult to generate particular types of evidence. Moving on to the next slide then, please. A further highlight I wanted to talk about is how we want to support a comprehensive evidence base and broader ranges of evidence. And we propose broad improvements to how we source and synthesize evidence, how we bring it together, how we present it. And that, most importantly, presents improved clarity and predictability, both for people submitting evidence to us and for our committees, in the expectations that we have of evidence, emphasizing the importance of the highest quality of evidence that we're able to source, but considering it proportionately to the context that it's being looked at in. Real world evidence is an area of particular interest, and we highlight here the really broad range of applicability of real world evidence across different evaluations in different circumstances, different types of evaluations, different types of real world evidence. And we want to support that and encourage that. And to do that, we present guidance on appropriate ways to use this type of evidence and how to develop it such that it's as high quality as possible for the circumstances being used. And that guidance comes both through this methods review and through wider activities within NICE, going beyond this piece here. Then thinking about broader types of evidence, again, we're presenting improved guidance so we can give further clarity and predictability for people developing evidence on things like surrogate outcomes, for example, also expert elicitation techniques where we can bring evidence from experts into evaluations, and other broader sources of evidence that I haven't mentioned here, things like qualitative evidence, for example. And these together present that package where we really support that broad and comprehensive evidence base, getting the best out of the information and evidence that we can. Thank you. So if I could move on to the next slide then, please. The final step then is to bring together the methods across our evaluation programs with the objective here of future-proofing our methods across the different types of evaluations as the distinctions begin to blur or to change between different types of technology or different types of treatment. And to that end, we then present a combined manual where we bring together the 4 programs that Richard highlighted. into a single manual, and we present it here for information. It's a draft manual here for information that describes the shape of that manual and how it sits together and how we propose to present our methods guidance in the future. And then looking forward from that, the next step is, of course, once we've completed this consultation and heard your views and taken them on board, to begin to implement this in evaluations, looking to do that once the final methods guidance is published. Beyond that, then, we propose that this become our last sort of large-scale methods review, single methods review, but rather to move to something that's more agile, more modular, so we can take individual developments more quickly, more promptly, rather than a single all-spanning methods review. And that's a project for the future. And with that, I'll hand back to Richard for the next slide.
Thanks, Ian. So I guess the question that you're asking yourself is, what does this mean for me? So just a reminder, this is only one component of a number of broad improvements within health technology evaluation and access that NICE is working on. However, specifically, the changes that we are proposing in this consultation will have several effects, and that includes being able to support prompt access to new and innovative health technologies. The new methods will also provide a clear value benefit in a fair and equitable way, where treatments get treated in a fair and equitable way, and also in an evidence-based manner. They will also help clarify how we explore uncertainty in the way that we present it, contextualize it, and ultimately how committees consider it. The methods will also provide further support for the adoption of a more comprehensive evidence base, as Ian was mentioning, and that will take full advantage of the best evidence that's available at the time. And then the methods will also provide an increased clarity and consistency and transparency for the companies that are involved, for patient groups that are involved, and also for the NHS and across committees as well. And finally, they'll be able to help ensure that the decision-making is responsive, flexible, predictable, and as robust as possible. So I think Mindert already mentioned this, but if you have any questions, please submit them via the Q&A function. And with that, I think we'll take questions now.
Thanks very much, Richard and Ian, for a very comprehensive insight in these proposals. And again, just to reiterate, we're talking about the methods today, but there's 3 further webinars where we will be talking about highly specialized technologies, the process proposals, and go in a little bit more depth into the modifiers. You reiterated that, Ian. We're going to be joined by Mark Rasburn. He is a senior advisor, a senior public involvement advisor, I should say, in the public involvement program at NICE. Mark, are you online? Hello. Thank you very much for joining us. And it is appropriate, I think, to therefore kick off with the first question we've received that specifically addresses the impact on patients. So could you perhaps clarify how we have assessed what impact the methods will have on different patient groups? So say, for example, people with cancer, people with rare diseases, or indeed people with other conditions.
Yeah, thanks, Minder. And it's a good question to start us off with. So in the development phase of this review, we established task and finish groups, which had participation from patient organisations on each one. And these groups explored the impact of possible outcomes and options, one being the benefit realisation group. We do have a webinar specifically looking at modifiers, as Minder has previously said, which will go into a lot more detail. But as an overview, in this area, we explored how different options might affect different types of condition and different patient groups. We also thought about how these proposals would impact patients across the NHS, as Ian earlier mentioned in the presentation, such as considering how any additional costs or additional modifiers would displace healthcare from others accessing and using the NHS. And along with these working groups, we also consulted on these proposals, as Richard earlier mentioned, to listen to what impact they would have on different patient groups. And again, this is another opportunity to get that feedback. In the next stage of the review, and as we develop the final methods and the implementation plans, we will continue to explore the impacts of these methods. So, for example, one option we're exploring is using case studies to consider in detail how different methods interact for particular types of patients and different patient groups.
Thanks very much. Well, really, really impressive interaction with patient organizations. And indeed, just to reiterate for everyone listening, the consultation is open to mid-October. So there's ample opportunity to engage with the proposals we're making. And I should also reiterate that there's a brilliant set of supporting information on our website, a very easy to comprehend and easy to interpret material that explains what we're proposing in these various changes. So perhaps an easy question to Rich in first instance: when can we expect these changes to be implemented in actual HTA submissions? Because this is the second consultation. When can we see the change really happening?
So we envisage that the changes will be starting to be implemented in the beginning of the year, so in January 2022. But between now and then, we do intend to do some implementation work. So that will watch this space, and we will keep people informed as to how they can get involved in those different steps during the implementation phase.
And maybe you could also answer this one then. Is this only for single technology appraisals or also for multiple? Is this for highly specialized medtech? How broad is the methods update scope?
Sorry.
Rich, whoever. Rich, you go ahead.
Yes, this does cover all the topics, all the areas that you mentioned. So medtech, diagnostics, highly specialized technologies, single and multiple technology appraisals. Yes.
Perfect.
That's right. And just to add, I think I spoke a little bit about one of our ambitions to align across the programs and to make things as consistent as possible between the different types of evaluation. Now, that doesn't necessarily mean they'd all be the same, because there remains a case to have appropriate differences. So there are differences between medicines and medical devices and highly specialized technologies and diagnostics. So we present then a combined manual that aligns as much as possible those methods across the programs, but there are some relevant differences. So you will read, as you explore the consultation, some talk. For example, on the modifiers, there is a case for some relevant differences in how we think about different aspects of technologies, of medicines and highly specialized technologies in particular. There's relevant ways that they are different. It is right that we highlight those and we're clear about those. So hopefully you can explore those in the consultation papers.
And Ian, just to follow up on that, as we're used to now, we have methods at NICE that are more, really based on principles, and then we have a set of technical support documents. And I imagine that if I think about these methods, these are very much principle statements, aren't they? Are you expecting to produce implementation materials that will be helpful for people later down the line?
Yes, indeed. Yeah, I think that would be a really important thing that we can do. I think Rich described that we do plan to develop some implementation strategies, some approaches, and further work to do on that. One of the components of that will be some updates to the technical support documents, which will provide some of that further detail on exactly how you go about doing some of these techniques beyond the principles that we describe in the methods guidance. And I think there's some other work that we can do with individual stakeholders, with our committees, with NICE colleagues, for example, to explain and make sure everybody fully understands the methods and support those with materials, documents, training sessions, for example. I think we can look forward to a very comprehensive approach to making sure these are implemented, knowing that the 5 topics are quite broad, and while there are some topics that are particularly prominent, we want to make sure that everyone fully understands the full breadth of those methods improvements, so we can really get the full benefit from them and really realize that the benefits of those improvements.
Mark, if you think about these methods and the proposals made, how have we reflected patient and public preferences in the methods? You talked a bit about how we worked with patients, but where do their preferences come into play?
Yes, so I suppose it's best kind of starting what we currently have. So we do currently have kind of a fairly robust methodology for how we include patients and the public across our health technology programs. And this is kind of using patient and public involvement, which helps to kind of understand what these preferences are, to help us to develop the appropriate guidelines and the guidance, and ensure what we're developing is actually appropriate for what patients need. So we want to continue with what's working well. So for example, we're going to continue having 2 lay members on our committees. We'll have open consultations. The lay members are equal decision makers. But what we found is there's kind of a disparity between different practices depending on the program. So what this methods review wants to do is kind of standardize the opportunities for patient evidence and patient involvement across all of our programs. So one example is our kind of patient expert submissions, which was currently only happening in our technology appraisals, but not for our diagnostics program or medtech programs. So areas like that, we wanted to kind of expand kind of good practice, which is happening in silos across all of it, and have that kind of standardized approach. In the methods document, you'll also see that we're proposing using more evidence from people's lived experiences. And this is designed to kind of better reflect what it's like to live with the condition in real life, what the different patient preferences are, but also to help clarify the circumstances and the differences in evidence in both their strengths and limitations, to help NICE and our committees to kind of fully understand what the patient preferences are and where shared decision making and patient choices might come into kind of the discussions. There is more information kind of about how we're going to do this in the processes document, and we're going to have a webinar on that. But I suppose the kind of key areas for patient preferences and patient involvement are using kind of real world evidence, increasing our use of patient evidence, and also ensuring that the same opportunities for NICE to gather that evidence is included across all of our programs and standardized to a high level. So using what we currently have and building on it to kind of improve both the use and the impact of the evidence to help us kind of decide and understand what those preferences might be.
Great. Ian, Richard, so okay, so that's the patient evidence coming in and preferences coming in. How are committees supposed to weigh all that evidence? Are there statements about that in the methods update?
Yes, I mean, I think committees have a lot of experience of weighing up exactly this type of evidence. So the deliberative approach and the structured decision-making approaches that our committees have been using for a long time have proved very valuable in doing that. So one of our objectives then is to just really make sure that we make the most of that evidence so we can present it so that they can deliberate on it. I think a further thing that we've done is, for example, in building the decision-making framework and looking at the modifiers, for example, we present for committees an understanding of how society values these particular things. So for example, with the severity of the disease, we present to the committees an understanding of what value society as a whole places on these particular factors or these particular considerations. To allow the committees to take it into account in line with the preferences for the country as a whole. So to take into account the severity of the disease, as an example, consistently with the way that we understand from the evidence that people do value that as a consideration. So that builds into a structured decision-making framework that allows the committees to deliberate and use their judgment and build on that evidence in a holistic way, but also reflect the values of society appropriately.
Great. Of course, as we all know, real-world evidence is definitely a great part of the methods proposals and how we're asking our committees to look at a much more comprehensive evidence base. We've got a question here from Dan Ollendorf, who we all know is a great colleague from the United States. So Dan, I've got no clue what time it is at your place, but it's great you're online. But you now disappeared. The question the question disappeared.
It's in the answered section. So it says.
Is it in the thanks for helping me out, Rich. After 18 months of Zoom, it still is a surprise how these things work. So Dan, you ask, at initial assessment, real-world evidence will have limited utility. In terms of improving the evidence base that does exist, how will NICE engage industry and other stakeholders to address limitations in the initial evidence package? For example, for a rare disease drug or end-stage cancer drug studied in only a single-arm settings, is there guidance on historical control sets or other supportive evidence that could be provided or that should be provided to NICE? Who wants to answer that one? Ian?
Yes, I can talk about that. I mean, I think I wouldn't undersell the utility of real-world evidence. I think it has some important limitations, of course, and there's particular limitations in establishing the overall effectiveness of a medicine, for example. And we know then that a well-conducted randomized controlled trial remains really the gold standard for that particular use. But there's a number of uses where I think we can get a lot of information from real-world evidence. I think things like clinical practice, what's happening in the real world of medicine, and how that impacts on the patient experience and the benefits and the costs of a health technology. It can have some really important uses in diagnostics context. As another example, understanding the full pathway of care and how that might change or with a change in the diagnostic approach. Medical technologies, real-world evidence can be really valuable for people's experiences of using the technologies and how it works for them in practice, what limitations or benefits they find from it. So really spanning the full breadth of a health technology evaluation approach, real-world evidence does have a lot of potential use, I think. And I think it's great that we are able to support and encourage that. But I do absolutely take the point that there are some limitations of it. And I think the question around how we're going to engage with stakeholders to make sure we improve that evidence base is really important. So one of the things that we're doing is presenting some guidance straight off on how we can make the best use of real-world evidence and set some standards and expectations for getting the highest quality real-world evidence that we can. So that process begins here, but it doesn't end here. There's certainly not the end of the road for real-world evidence at NICE. There's a lot more work that can be done across the Institute, I think, to provide further information and guidance on that. On the specific questions around single-arm trials, and historical control sets, again, there are areas that we can develop. The principles that we set out in the methods guide, in the methods proposals that we present, do address that, albeit not necessarily directly, because there's such a breadth and a variety of different types of study design and study approach that we can take. So we set out the principles here, rather than dictating specific methodological approaches. But then that leads into your question earlier around the further supporting information and guidance that we can give, technical support documents, for example. And that's another area where we can build even further onto the methods guidance to really support that top quality, really valuable real-world evidence.
Brilliant. A related question to real-world evidence from Felipe Vera. But now it's gone. I must not be good at this bit. About the real evidence approach. Oh, no, it's still there. This is going to be a more methodological area of effectiveness, is his question, or in the possible economic evaluations or modeling. And in particular, I thought this was an interesting part. How does the new approach to QALY lost due to the disease, as is proposed in the modifiers, how will that work with real-world evidence? Are people expected to submit further evidence, or is it really part of the next webinar, Ian?
Yes, I think the consideration of displacement and loss of healthcare, or displacement of healthcare elsewhere in the system, probably will be a topic that we can explore a little bit more in the next methods webinar, where we talk about modifiers. So that will be, and particularly the severity modifiers. So that will be an area
Okay.
where we can explore that. But I think the other part of the question around the real world evidence, I think, as I say, there's a really broad range of applications of real world evidence, and I would see it having a potential role across any aspect of health technology evaluation. So it could be that we're talking about effectiveness evidence, but also in the economic evaluations and the economic modeling, real world evidence to establish resource use is a really potentially valuable avenue that we can explore. So what we have tried to do with the proposals and with the methods guidance is really stress that we're not only interested in a particular narrow understanding or view of how real world evidence can be used. It really is across the board. But the principle of the highest quality evidence possible, and that it be considered and evaluated and explored and critiqued proportionately to the circumstances being used, whether that be a particular type of technology or a particular application or a particular type of uncertainty, whether it be something that is a very significant effect on the results, or whether it's something that's perhaps more minor, so might need less scrutiny, that we do that proportionately and reasonably and appropriately in each circumstance.
There's a question about the overarching goal in making these changes, and we already discussed that, haven't we? Is there anything that you want to add to that?
Just that, I mean, the whole point of this methods review is to keep NICE's methods as up to date, as current, as cutting edge as it should be, to reflect the changes that are happening in the development of new technologies and new types of technologies that we're seeing. So this is a response to that, and I think the change to the modular approach of future reviews is also a response to that, so that we're more flexible in the way that we can update, and we don't have to make these huge strides in changing from one methodology to a completely new one. Although this, I wouldn't say that this is a new completely. This is an evolution of the existing methodology.
Someone asked about the introduction of the disease modifiers. In NICE's approach to introducing severity of disease modifiers, there's a graduated approach where these modifiers are applied to both medium and high severity indications. And we're going to talk about that in a different webinar, as we've said a couple of times. But this specific question is, why has this graduated approach to decision modifiers not been considered for rarity of the disease? So what is the difference? Why are we doing this quantified work for the severity modifier, but not for rarity? And there's then the subsequent question: what support do NICE propose for manufacturers developing novel new technologies for rare diseases? So perhaps on the first bit, Ian.
Yeah, that's a good question. And I think this goes back a little bit to the evidence that we explored in the first stage of the consultation of the methods review, and that what stage that Richard described, where we looked in detail at the evidence for societal value. So looked in detail at how society and people across the country view different factors and what value they ascribe to them. And what we found in the terms of rarity was there really isn't evidence that society puts greater value on rarity itself. In of itself, rarity is not really something that people particularly put greater value on. And for that reason, we considered that there wasn't a case to introduce a modifier specifically for rarity. In contrast, what we found was there was evidence that society does place a higher value on those health benefits for the most severe diseases. And that's why we present the case for change that we did, and hence the proposal that we presented at this stage. Now, having said that, in practice, a lot of rare diseases are indeed severe. And one of the benefits of the severe disease modifier is that we broaden the modifier beyond what was previously a relatively narrow view of specifically end-of-life conditions that we looked at before. So we broaden out into a wider range of conditions and circumstances, and that can include rare diseases. So that means that where a rare disease is causing very severe symptoms or very severe effect on people's lives, that is appropriately reflected in the values that we ascribe to it and the values that our committees can place on it. So I think that has an important benefit, I think, for rarer diseases. I think there's also a number of other things in rare diseases that that are features of rare diseases and features of evaluations in rare diseases, where our methods have been improved further elsewhere. So, for example, we know that generating evidence from gold standard randomized controlled trials can be very difficult in rare diseases. And that's one of the reasons why we want to really leverage that benefit of real world evidence and also move into other broader sources of evidence, such as expert evidence, qualitative evidence, surrogate outcomes, for example. So these all together combine to make sure that we're getting the best of the evidence that we can and as much information and leaving as few uncertainties as possible from the evidence that's available. Then when it comes to the uncertainties, we also recognize that that evidence is indeed difficult to generate, and those uncertainties are to an extent inevitable. And we want to again make sure that those rare diseases are not blocked by a disproportionate approach to uncertainty and a lack of flexibility. So we propose to really clarify and codify and clearly explain the flexibility that that is available and has been used in the past, indeed, by committees. So committees have used this their judgment in the past to reflect this sort of flexibility. But we can clarify that, we can codify, we can explain it and make sure it's very clear how we are applying that flexibility when it comes to uncertainty in those circumstances where evidence generation is difficult, where it's challenging.
Thanks very much. Mark, do you think, if you think about patient involvement and how patients interact with these methods, will it become easier for them or more difficult? Because it feels quite complex, doesn't it? What we're talking about and what's in the consultation. Have you got an idea how we can make it easier if it is ever more complex?
Yeah, I suppose the simple answer is I hope it makes it easier. The whole aim of this is to kind of standardize our approach. So whether patient organizations are attending one of our technology appraisal meetings or diagnostic meetings, we should have a kind of a standardized approach to what patient involvement and patient evidence is being included in those committee discussions. So they have kind of an awareness of the kind of the methods and the processes which we use as an organization. But I think as part of my team, the public involvement program, there's also the role of kind of improving the support which we have. So this looks at kind of the toolkits we make available, templates and the support to essentially make sure that we're communicating with patient organizations and our patient experts to identify where the gaps in knowledge are, where the gaps in evidence are, where the kind of patient experience is needed to influence the decisions and influence committee discussions, and essentially make it as easy as possible to involve and engage with NICE as we can make possible, because we have to kind of appreciate we're working with organizations who are global leaders in their area, as well as those ultra rare condition areas, which it might just be a volunteer sat on a laptop. So we need to make sure we're adapting our support depending on the need of our stakeholder to either provide more information, or if they're well versed in the NICE process, they might not need as much support from my team. But we really wanted to kind of ramp up the kind of, I suppose, the engagement, the communications, to make sure the information that they're giving us is beneficial to the committee. And in the same kind of scope of that, we're also starting to ask our committees how the patient evidence has influenced the discussion and the outcome. So we can feed that back and constantly learn what is having the biggest impact. Is it the way we're presenting? Is it the type of evidence? But essentially making sure that evidence is having an impact and not just a tokenistic approach for involvement.
Yeah, because there will be, I think, Ian and Rich, there will be more on visualization and how we present the information that committees have taken into account. I know Polly Moyer asked a question specifically to a product, so perhaps not to go into the detail here, but she wants to understand better how these methods work for a new technology that's being introduced into the UK. What do certain terminology we're using? What does it mean? And the answer is probably you should contact Mark and his team, and they can discuss that in more detail with you. There was a question here from Jose Diaz, and I mentioned the importance of understanding the societal value derived from innovative, clinically and cost-effective technologies. And he wants us to expand on how exactly NICE is planning to identify, evaluate, and incorporate in decision-making societal benefit and spillover benefits from innovation. Are we going to do that, Ian?
I think that would be a really good candidate for something for us to look at in the next stage of a modular update. I think there's definitely a case for us to think again about what evidence and types of value we want to take into account. So what we've done at this stage is we have clarified how we approach innovation and how we, particularly around the uncertainty piece. So this is where that's a particularly important consideration. But I think there's definitely some value in us thinking about things like spillover effects from innovation in the context of a modular update, thinking about the implications of that. So that wasn't something that we presented in the case of change. It wasn't something we identified enough evidence to work from at this stage, but that doesn't mean that it's something that we are finished with. There's definitely a longer term piece that we can move on to within a modular approach.
But we are taking innovation into account, no, in our uncertainty proposals. Yeah, exactly.
Yes, absolutely. Yes, no, we'd absolutely take it into account, but I think it's that longer term piece around the value of spillover and scientific externalities, those sorts of technical concepts, but build on really important societal value that we can bring into our evaluations in a meaningful way, but does require that more sophisticated, longer term deliberation.
There's a couple of questions around the modifiers that perhaps are more for next time. So, for example, one around what would happen if future research on societal value of severity that we're signaling we will be doing, if it showed that people do not value severity more highly, what would happen? How can we make sure we don't then go backwards in getting patient access? How will we balance displacement costs and providing adequate incentives for advancing exciting, not existing, new technologies which have high initial costs? So that second is perhaps a different question. So the first one about severity we can talk about in the modifier webinar, but maybe the second one, how will NICE strike a balance between considering displacement costs and providing adequate incentives for advancing exciting new technologies with high initial costs, the cell and gene therapies? Is there anything you can say about that, Rich?
I mean, there are a number of different mechanisms that NICE has in place to encourage this sort of development. So apart from the methods update that we're engaging in now, there are things like the Innovative Drugs Fund and other mechanisms that would allow for that to happen. So I guess thinking about this as one of many a suite of options that are available. This is not a one-stop shop. We look at the wider view.
Yeah. There's a couple of questions around the implementation of when these proposals will apply to either reviews or new technologies, and we should discuss those on another occasion. I think perhaps in the webinar around process. There's also a couple of questions around discounting, and specifically, what are the overlapping issues and how we're intending to support further discussions. I think that's probably beyond the scope of this specific webinar, considering that that's something that isn't really instigated by NICE, those discussions, but has to be happening between the health system partners that we work with. There's also a note about the method standards framework using real-world evidence. And of course, that's important work that's happening already. And perhaps a very final question about the modular updates. How do we envisage those to work?
I think that's a really important question, and it's
Yeah.
something that we need to design. To be honest, it's something we haven't yet established how it's going to work, but I think we need to do a process of designing how we go about that. Something that's really important is making sure that we have the right engagement with stakeholders. It's not something we would ever want to do on our own in a silo. We want to have engagement with patient groups and patient representatives and industry and academia, academics, and the wider world as well. I think there was a question somewhere about international HTA organizations. Yes. That's something that we can design into that modular approach as well. I think some of the ideas that I was thinking around are designing different approaches for different types of updates. So where there might be smaller clarifications, we might have a smaller approach that would be proportionate in that case, whereas something larger, such as a modifier, might need a more sophisticated longer term piece. And we can be really dynamic with this. The whole idea is that we can be very flexible and dynamic and move quite fast with these things and not be stuck to a very fixed long-term large scale project, but make the right changes at the right time in a way that's meaningful, so we can keep those methods right on the cutting edge and moving as quickly as possible and as dynamically as possible.
Okay, there's a very final question. I think I should put that out there. Could you explain the rationale and motivation for keeping the proposal on subgroups, given the strong objection from a variety of stakeholders? Rich, can you just briefly attend to that, and then we'll close the meeting?
Well, I think there wasn't opposition. I think that there was a mixed views, but but in terms of what is included in the consultation, it's already what committees can do. So they can already make recommendations that are based on the evidence that's available to them, and if a population is not cost effective, then it should not be recommended in that population. So I think it's consistent with the approach that committees already take.
Brilliant. Well, thanks very much, everyone, for participating. I'm sorry we haven't been able to answer all the questions you put in, but we should move to the final slides. We've got, as we mentioned at the very beginning of the presentation. So next slide. I hope we can see those still. The future events. We've got the highly specialized technology selection criteria focus on the 1st of September. That's next week from 4 to 5. Then we have on the 8th of September, our process and topic selection proposals from 1 to 2. And the method review, a focus on modifiers. And there's been so many questions today already. That will be on the 9th of September. And you can register at www.nice.org.uk/news/events for those webinars. And finally, our final slide is to really encourage you to share your views on www.nice.org.uk/methods-review. The consultation closes on the 13th of October, and there's an email address if you have any further questions. Thanks, everybody, for participating, in particular, Rich, Ian, Mark, and the team behind the scenes. And we hope to see you at our next webinar next week on the 1st of September. Thanks very much. Have a good day.